I would request Dr. Saswato Majumdar, consultant physiatrist, healthcare at home, Kolkata, rehabilitation of replacement surgery.
Good afternoon, everyone. My topic today is post-TKA rehabilitation, and it's a brief introduction. So let's begin. Total knee arthroplasty is one of the most common elective procedures performed worldwide, and the number in India is slated to grow to the highest rate in the world from 2020 to 2026. Indian Joint Registry has been established by the Indian Society for Hip and Knee Surgeons, and they collect the data including the Aadhaar, PAN, such unique IDs, thromboprophylaxis, untoward intraoperative events, IGR consent and type of anesthesia, and the type of prosthesis, and other demographic details. From there, we learned that the commonest diagnosis for TKR is basically osteoarthritis, which is 98.5%. And other than that, rheumatoid arthritis and other traumatic events can lead to TKR. So the 3/4 of the TKRs being done in India are posterior stabilized prosthesis, compared to around 20.61% are cruciate retaining type, and the other including the hinged knee and the two more prostheses made up about the 3% of all surgeries. So as you know, arthroplasty involves the reconstruction by natural modification or artificial replacement of a diseased, damaged or ankylosed joint. So this is can be unicompartmental, bicompartmental and tricompartmental. Here we are talking about the tricompartmental knee replacement. So the types of prosthetic design, multiple types are applied these days. The commonest is, as I said, posterior stabilized. Then cruciate retaining, constraint non-hinged, and constraint hinged are the most common types. So previously we used to do conventional TKRs where we used to have a larger incision. Now minimally invasive TKR has taken over, where the size of incision has reduced from 10 to 12 centimeters to 5 to 7 centimeters. And despite being a reliable and consistently successful procedure for individuals with severe degenerative arthritis, studies indicate that as many as 1 in 5 patients undergoing primary TKR may express dissatisfaction with the results. And the reason for this is basically not getting proper rehabilitation. So proper TKR rehabilitation should start before the surgery, what we are calling as pre-rehabilitation and post-surgical rehabilitation. So post-operative complications in case of a TKR patient usually includes these. So DVT with PE, patellar instability, patellar component fracture, the patellar clunk syndrome, rupture of extensor mechanism, peroneal nerve palsy, arterial injury with thrombosis, periprosthetic fractures, which are more common in case of rheumatoid arthritis and osteoporosis, and notching of the femoral condyle during surgery, as demonstrated by my previous speaker, is very important part. And then arthrofibrosis, infection and metallosis are also common post-operative complications that we may see in a post-TKR patient. Now, prognostication. When a TKR patient comes to us, the first question comes, when will this person walk, or when will they start walking properly? So poorer locomotor outcomes are usual with women with a high body mass index, multiple comorbidities, high intensity of knee pain. This we are assessing before the surgery, and restriction in the flexion amplitude, deficits in knee strength, particularly quadriceps strength, and low concentric push-off work by plantar flexors and low concentric action of the hip flexors during early swing phase on the non-surgical side. So what we can also do is we can take a 6-minute walk test and a timed up and goes test to assess the ability of the person. So as you can see, in case of minimally invasive surgery versus traditional or conventional method of total knee arthroplasty, the SLR is recovered in case of post-operative day 1, in case of the minimally invasive surgery, while the patient who underwent conventional surgery, they are unable to do SLR on day 1. And walking without cane is post-operative day 8 in case of minimally invasive surgery, while traditional total knee arthroplasty about 6 to 14th day with assistive devices. A knee flexion at 3 months after surgery is about 122 degrees of flexion versus 110 degrees of flexion, and knee flexion at 1 year after surgery is 125 degrees of flexion versus 116 degrees of flexion. So in terms of rehabilitation, the minimally invasive methods including robotic surgeries are of course the better ones. Now the required knee ranges of motion, as you see, within the full 125 degrees of flexion, we require different ranges for different activities. So walking in stance phase, it requires 15 to 40 degrees, while in swing phase that goes to 15 to 70 degrees. Stair climbing over step by step is 0 to 83 degrees, but the maximum is stooping down and tying a shoelace, where it's coming to 117 degrees and up to 106 degrees. So sitting down and getting up from that posture is one of the most important parts. Now, prehabilitation begins with assessment. As we said, that we first assess the patient's previous goniometries. We try to check the range of motions of the patient. We do our manual muscle testing to assess the overall muscle strength of the patient, particularly in the lower limbs as well as the upper limbs, because initial stages when the patient is ambulating, they will be ambulating with support. So in that level, we require a proper upper limb strength. And then we also assess the functional abilities by timed up and go tests and the 6-minute walk test, though it has been advised that the 6-minute walk test may not properly capture the data, and nowadays a 30-minute walk test is being investigated for this, so that is another thing. Controlling the comorbidities prior to the surgery is very important, because we cannot ensure a proper outcome unless the patient has properly controlled blood sugars and other comorbidities. So that is very important part. Strength and flexibility training should start before 6 months before planning a TKA surgery, because this is a planned elective surgery. It's never emergent, so we can do a proper training and we can initiate the patients a habit of exercising, particularly those that they will require in the first initial phases of the TKA in the post-operative period. So starting with the strength training as well as the flexibility training is something that we should do. Nutritional counseling is very important, because mostly these TKA patients, they will be obese or they will be having some sort of disorder regarding this. So correcting the nutrition, weight loss advices and controlling body weight is also very important. Along with this, patient and caregiver education. What are they expecting through the TKR process? What are they going to get after the TKR? When are they going to ambulate, and how are they going to ambulate? All these things, they need to be explained to the patient clearly beforehand, before going into the rehabilitation process. So medical management immediately post-operative period, we know that DVT and PE, as I showed, that one of the most common complications. So that is the first thing that we should start with, prophylacting that. And warfarin has been found to be superior to low molecular weight heparin on this term. And intermittent pneumatic compression is something that we can also use, and it should be used up to 10 to 35 days after the surgery. Then analgesia is very important, particularly because these patients will not ambulate if they do not feel pain-free. So starting with oral opioids in the acute phase, and then we can go up to performing certain nerve blocks, like a femoral nerve block, or infiltrating the surgical site with different nerve blocks and all the other options. Or we can maintain an epidural catheter initially if the patient is very much complaining of pain. Dry sterile gauze dressing till drains are removed. Stitches are removed on the 10 to 14th post-operative day. Application of a knee immobilizer in this period is important. Correction of blood draws, so autologous transfusions, epoetin and iron supplementation is another option. Starting with rehab management, we first establish the goals, so to relieve the pain and to redevelop comfortable musculoskeletal function, to use joint protection techniques initially, to avoid overstressing the prosthetic joint. This is very important. So we begin the knee range of motion immediately post-operatively using a CPM machine. Total weight bearing to tolerance with crutches and ad-lib ambulation is started on the first post-operative day using crutches or a walker. Active assisted flexion is the basic management done under a supervision of a physical therapist. Now, this is a sample program that I've put here, but there are multiple different programs, and we cannot really judge one over the other. The jury is still out on that. It requires further studies. So there are 4 phases of total knee arthroplasty rehab. We start with the inpatient acute phase, which is for first 1 to 5 days and is a post-operative period. And the primary problems addressed at this level is edema, pain, limited range of motion, limited strength, limited bed mobility, transfers, and limited gait. And there are multiple different interventions at this level, including the CPM, as I mentioned. Then at the second phase, which is the extended care or skilled nursing inpatient care, this can be done at inpatient rehab facility. Is usually 6 to 14 days, and this is similar to the problems are similar to the initial phases, but the progression criteria is that there is no sign of infection or no significant increase in pain, or there is no loss of range of motion, or there is no discharge from the acute care. So all these elements has to be fulfilled, and interventions at this level is including those previously done are the transfer training. The focus is more on the transfer training and progressive gait training using different assistive devices and supports. Then nextly, at the third phase, where the patient is discharged at home and home care based plan is given, so 2 to 3 weeks at home, or a nursing facility depending on the care of the patient. So there is again similar criterias, and the problems are usually the limited range of motion, limited strength, and difficulty with gait. And here at this point, they should be able to perform the transfers, particularly bed to wheelchair and other transfers, including the car transfers and the gates. So that is more focused here, and progressive weight bearing. And then outpatient care, OPT-based care, should be continued for 3 to 8 weeks. And here, the patient is no longer homebound. Patient can ambulate and is a limited community ambulator at this level. And a limited range of motion, limited lower extremity strength is the primary problem at this level. And we should be able to initiate different activities, including the closed chain and the open chain activities. Also, at this point of time, if we have an option of an aquatic therapy, that can be utilized. So the exercise precautions that needs to be mentioned is that we need to monitor the integrity of the surgical incision during the knee flexion exercises, particularly in the initial phases. Then we should postpone SLRs in side lying position up to 2 weeks for cemented arthroplasty and 4 to 6 weeks for the non-cemented arthroplasties. And we should discuss with the surgeon to decide when it is permissible to initiate exercise against low intensity resistance. If posterior stabilized prosthesis is applied, we should avoid hamstring strengthening in seated position to reduce the risk of posterior dislocation of the knee. Tibiofemoral joint mobilization techniques can be used, but they need to be monitored properly, used very cautiously, because they can cause dislodgement of the prosthetic components, and there may be periprosthetic fractures. And postpone unsupported or unassisted weight bearing activities, that is basically the open chain activities, until strengthened quads and hams are sufficient to stabilize the knee.
Another 1 minute.
Yes, sir. So TKR failures are usually something that we don't see that much these days, but it used to be a lot more. Now we should focus for the early loosening, which is within the first 2 years, which may be mostly due to the mechanical and surgical factors and due to fixation failure, and the late loosening is beyond 2 years, which is more commonly in the 10 to 15 years and due to biological factors. I will not go into the details of these. Mainly what I want to mention is, first, I have mentioned CPM in the initial phase. So there are multiple studies on this, and it has been shown that CPM may not be that much helpful. So the current meta-analysis are suggesting that you may or may not use CPM. That doesn't really matter. High velocity exercises and high intensity exercises are actually better for that. And thirdly, outpatient therapy is as superior as inpatient therapy. And early therapy is the most important part. So in summary, post-operative rehabilitation following TKR should facilitate patient recovery and improve quality of life. There remains a lack of consensus against the duration, the intensity, and the delivery of rehabilitation. Continuous passive motion and inpatient rehabilitation may not provide additional benefit. Early rehabilitation, tele-rehabilitation, outpatient therapy, high intensity and high velocity exercises may be successful. Weight bearing, biofeedback, neuromuscular electrical stimulation, and balance control exercises appear to be beneficial adjuncts to the conventional rehabilitation. Thank you. These are my references.
Thank you, Dr. Saswato. As we are going short of time, not going to invite any question. Thank you. We can proceed to the next session.
Actually, both of them, they pointed out to major reason why patients are not satisfied after TKR, which the physicians and surgeons can control. One, the surgical issues, they may be addressed by SOMO by using robot and etc. etc. And of course, very much important what Saswato just pointed out, both prehab and post-hab. These two things are more important to prepare the patient before we do TKR. That is very much important, and post-operative rehabilitation. Thank you so much, Saswato and Chomo. Excellent.
I want to add. I am looking after TKR since 1999. My observations for not being happy, apart from surgical techniques, two things for rehabilitation. That when we are dealing with knee replacement, we have to keep in mind the hip muscle improvement as well. Number one. Number two, many of the patients.
Hip and spine.
Absolutely. And many of the patients retain some sort of flexor deformity, fixed flexion deformity, post-surgery. So that is another issue during walking, they feel uncomfortable.